Okay, when you are ready, you can start. Done. You can start, Hutan.
Yeah, colleagues, good morning, good afternoon, good evening. Today we have a session two, but before proceeding to the session, we will briefly go through what the course does it mean, and then how we are planning to progress, and then after that we proceed to the today's session. Thank you for coming and making your time today to join this session too. Thank you. So we have interpretation both in French and Portuguese. So if, you can click on the interpretation, and then you can go for your for the choice you would like to follow. Next slide, please. Then the partners in this course is the Global Climate Consortium for Climate and Health Educations, the Columbia University, WHO Regional Office for Africa, Africa CDC, Climate and Health Network, collaboration for the engagement of climate change. We have the African Population and Health Research Center. We have the Ugandan National Institute of Public Health, and also African Research and Impact Network. Then we have the Build Health International Research Institute in Health Science, Burkina Faso. And then you can see all the partners here in the course organization. Next, please. Then the course objective is, number one is to analyze the climate-related health risk and be able to conduct vulnerability and adaptation assessment for health system and also facility using the WHO and the national frameworks. Objective number two, develop and implement climate adaptation and the resilience strategy for health facility, and also that address infrastructure, maintenance, workforce capacity, service continuity, and also emergency preparedness. Then number three is design and justify low carbon, resource efficient healthcare interventions, including sustainable energy, water procurement, and the waste management system. The fourth one is integrate and apply climate resilience principle into health system planning and the policy, also align with the national adaptation plan and health sector strategies. Finally, number five is to communicate and advocate for climate-related health risk and evidence-based solution to policymakers, communities, and cross-sectoral stakeholders using clear and targeted strategies. This is the five strategy. So we have 12 sessions every Thursday. The course is for 12 session. It's going to run from August 6th up to October 15th. So we have all those outline, and then to be followed by the session on the communication, education, and finalized by some support support program. So maybe we can look at how can develop the case study at the end. Next. Then the course has free, but it has a certificate of participation given passing the exam and attending the course at least more than half of the course. Next, please. We'll have attendance. Attendance is automatically recorded during the live Zooms. And so your individual attendance is only counted if you join using your personal Zoom link. Then you will your attendance is not occur if you don't join the link. So the YouTube view will not count toward the attendance. So there is a need to join through the Zoom link provided. The next slide, please. So we'll have the final exam. Then the exam must be completed using the same email address used to attend the Zoom sessions. So the exam also link will be sent on the final day of class, October 22, via email and then WhatsApp, and they will close on Sunday. Formally, 25 multiple is expected for 90 minutes. The exam is gonna to for 90 minutes. So for the session, we have 19-minute session. Then 35 and the 30 is allocated to the presentation. Then we have also Q and answers time for that. The next slide, please. So join the course with WhatsApp group for update and then information from the course planning. The WhatsApp is only for the information, not for taking the course. So rejoining is not possible. So these are the WhatsApp group is there. You can scan now. Next, please. So today's session is, which is the backbone for climate change, to address the climate change impact in health, which is very critical, assessing vulnerability and adaptation of the health system to climate change impact. So in this session, the first objective is to describe the current climate change and health vulnerability, adaptation assessment, and how such assessment form the basis for health system preparedness and resilience. Objective number 2 is analyze the difference between IPC AR4 and AR5 framework and apply the risk-based approach, including the role of hazard, exposure, and the vulnerability to assess and strengthen climate resilience in health system. Third, understand how to conduct climate health vulnerability assessment with the WHO methodology. identify population and health service most vulnerable to climate risk. Fifth, interpret climate projection to assess future health risk. Finally, to translate assessment finding into adaptation priorities. So the ultimate goal is to come up with the adaptation option. Today we have to distinguish the presenters. The first one is going to be presented by Professor Balai Semene from Addis Ababa University, Ethiopia. And then the second presentation is going to be presented by Dr. John Bosco from a senior lecturer from Makerere University School of Public Health, Uganda. Next slide, please. Hello?
Now you
Next
can
slide.
present Professor Belay Kutan, please.
Okay. Professor Balai is from Addis Ababa University. He is prominent in the climate change and health. Also, before that, he is working on the livelihood and all those areas. He was one of the front and in undertaking the vulnerability assessment in Ethiopia in 2015. He supported in that. He currently engaged also both in the environment, agriculture, and the health in assessing and then advocating for addressing the impact of the climate change also in the health sector. So this is what I can say in short. But if you go online, you will see what Professor Bala is doing in the areas. Next, please. So now, Professor Balai will continue presenting the session for the coming 30 minutes, and then we'll go to next to also Dr. Bosco later on. Thank you, and over.
Okay. Do you hear me?
Yes.
Okay. So it is really a pleasure to join colleagues from different parts of the world and from across Africa through this excellent initiative. And today I will introduce one of the most important tools for building climate resilient health systems, which is the climate change and health vulnerability and adaptation assessment. Commonly, we call it VNDA assessment. So this assessment is no longer optional. It is the foundation for evidence-based adaptation planning, helping countries, regions, and even counties to understand who is at risk, why they are vulnerable, and what interventions are needed to protect health systems now and in the future. So I will try to make my presentation as practical as possible from my experience. So in my opinion, the learning objective from this session will be to explain climate health vulnerability and adaptation assessment, and to describe the WHO methodology for conducting climate health vulnerability assessment, and identify vulnerable populations and health services if possible, and understand how climate projections inform future health risks and translate assessment findings into practical adaptation priorities. So I hope you will look at it. Are you hearing me?
Yes, we can hear you.
Yeah.
Okay. So climate change is already here. It's not something that we're expecting or anticipating. So the science is clear. The impacts are real. And the time to act is really now, particularly for Africa. So it is unlikely that the Paris climate targeting of limiting warming to less than 2 degrees centigrade, and let alone 1.5, cannot be achieved if we continue with this. So you can see in the UNEP report, which I was also part of it, the emission gap for 2035 is going to be about 23, million metric tons of CO2. So in that regard, we are expecting more heat, more climate change, particularly in this part of the region. So climate change is already here in Africa, and Africa is on the front line. The impacts are real. So Africa is among the most climate vulnerable regions. So despite, again, this we can make as an argument in the UNFCCC, despite its contribution, which is less than 4 degrees Celsius, 4% of global greenhouse gas emissions, and now Africa is warming faster than the global average temperature. It is between 0.3 to 0.5 degrees Celsius per decade since the 1980s. So current trends show, I think we have calculated for the different parts of the region. So rising temperature across all African regions is in the order of 0.3 to 0.5 degrees Celsius per decade. And more frequent and severe heat waves, then increasing drought frequency in Eastern and Southern Africa, particularly the Southeastern and the Horn of Africa are heavily impacted. And more intense floods in the West, Central, and East Africa, cyclones affecting South Africa, and expansion of the vector-borne diseases, and particularly climate change is impacted mediated, through the food system. So food system disruption in Africa is so immense due to climate change. So the consequence is increasing burden, including malaria, waterborne diseases, foodborne diseases, and other direct, impacts like heat stress, and greater demand for health services that we're finding more. And in many African countries, damage to health facilities is very visible, and reduced services is the continuity of services is getting reduced, and greater inequalities among vulnerable population, particularly the women and children, are heavily socially impacted greatly. Therefore, a strong health system, resilient communities, and sustainable future can be obtained if we can understand clearly the vulnerability of communities and individuals and try to implement sustainable adaptation options. Now, so why does climate change impact the health systems? So as you can see, climate change is already affecting every component of health systems. So the hazards are too many: increased temperature, heat waves, droughts, floods, cyclones, wildfires, and air pollution could be taken as risks, climate hazards or risks. And the health impacts include heat-related illnesses, the malnutrition, particularly Eastern Africa, Horn of Africa, very much, diarrheal diseases due to the foodborne diseases and waterborne diseases, malaria and dengue expansions, respiratory diseases, mental health, and injuries and other diseases are some of the health impacts. And the health system, is damaged in terms of the infrastructure, disrupted health services, medicine shortages, increased patient loads, and workforce stress, and financial losses are immense in the African continent. Therefore, we need a stronger health system, climate resilient future, and health for all in the African continent. So the dimension, now I will go to a little bit to the science of it. The dimension of climate vulnerability, which is first, let's understand what climate vulnerability or vulnerability is. It is the propensity or predisposition to be adversely affected by climate change, according to the IPCC. And vulnerability is shaped by three interacting factors. One is exposure, who or what is exposed. So it explains the degree to which people, communities, or health system experiences climate hazards such as drought, heat wave, floods, vector-borne disease, and others. And the second one is the sensitivity. This is how severely are they affected. It could be communities. So extent to which exposure causes harm influenced by age, health, status, livelihoods, and infrastructure. And the third factor is adaptive capacity, and it tells how well can they cope and recover. Ability to anticipate, respond, cope, and recover, supported by trained staff, preparedness, infrastructure, and essential resources, explains about adaptive capacity. So in a nutshell, if there is high exposure and high sensitivity and low adaptive capacity, we call it high climate vulnerability. On the other hand, if you have a high adaptive capacity and low exposure and low sensitivity, it certainly comes into low vulnerability. If you look into the diagram, I think in the African continent, it is possible only to influence or to go to the adaptation through the adaptive capacity, because exposure is difficult to control and sensitivity is basically a nature given issues. So if you are working on adaptive capacity, in physical terms, you can decrease the exposure and sensitivity of communities or that particular area. So health vulnerability assessment helps you to identify who is vulnerable, to which hazard, and why. This is a very critical prerequisite to the assessment. And secondly, you can assess environmental, social, economic, demographic, and health system risk factors and pinpoint high-risk population locations and health outcomes, and guides, this guides you targeted interventions, resource allocation, and policy, and also resilience building. And you can see the framework, vulnerability as a function of exposure, sensitivity, and adaptive capacity. Whereas, you can also decompose adaptive capacity into health system, institution, and community capacity. Then if you properly assess vulnerability, the hypothesis is you can establish location-specific, community-specific adaptation activities, and thereby you can improve the health system of your community or your country. So what are then the philosophical underpinning of vulnerability analysis? I think for some of you who are coming from academics, I would like to tell you some of the philosophical underpinning why we are doing this analysis. First, it is your intervention will be human-centeredness. It prioritizes human well-being, dignity, and security if you properly can assess the vulnerability. The second one is about equity and justice. It addresses inequalities and prioritizes protection of vulnerable groups. Thirdly, it's about system thinking. If you do good vulnerability assessment, it guides you to go into a system thinking which recognizes the interconnections among environmental, social, economic, and health systems. And the fourth principle is the precautionary principle. This promotes early action to reduce risks even when scientific uncertainty remains. Therefore, we call vulnerability assessment is a foundation or a foundational work for a very sustainable and location-based adaptation activities to bring sustainable health systems. Now, So why conduct a vulnerability and adaptation assessment? So why climate hazards affect the country? What climate hazards? I think every country, for example, if you go down to Mozambique, flood is a priority. If you come to my country, drought and flood are most important. Secondly, who is most vulnerable and where? The pastoralists, agro-pastoralists, women, elderly, or the EDI, the inclusiveness, the gender and inclusivity would be assessed here. And which health outcomes are most affected? And which health services, infrastructures are at the greatest risks? Therefore, the critical outcomes, if you do proper climate vulnerability, health vulnerability, then the outcome could be an acceptable national climate health adaptation planning could be created. Climate resilient health system could be established, and targeted resources could be allocated to those vulnerable communities. And you can also prioritize your investments, and monitoring, evaluation, and learning are also based on the proper vulnerability assessments at national and district levels. Now, so let me tell you from our work, I think Dr. Kutane remembers this. So what are the indicators? Those of you who would like to do at your country level or at your county level or at a national level. So the vulnerability factors we have said are three: exposure, sensitivity, and adaptive capacity. And looking into the health status determinants, in terms of exposure, we assumed that it's only climate. And the profiles are divided into two. The climate itself, the climate change, the changes in temperature, changes in precipitation, and hazards, which is the occurrence of extreme events, droughts, floods, and heat waves, could be considered depending on the relevance of the heat stress. And in terms of research, units of measurements are also included. For climate changes, the changes over time. For example, you can take over 30 years, changes over time in millimeters, and the number of populations supported with disaster risk management. Number of events affected population over the last 20 years could be, you can modify it, but depending on the availability of the indicators. Now, in terms of sensitivity, which is, we call it as a pre-existing condition. So there are two kinds of profiles there at a country or at community level. They are ecosystem based, which is geographic, and its indicators are suitability of the area for the climate change sensitive diseases. For example, the percent of the area prevalent to climate sensitive health issues, or malaria, or dengue fever, or whatever you call it. And the second one is about the demography. The demography, the social aspect, is also very critical. The proportion of the population who are vulnerable. And in many climate analysis, vulnerability analysis, the young children, women, and elderly are assumed to be highly vulnerable. And they are the indicators that you have to take it. And the percent of here, the percent of the young children's, women and elderly exposed workforces, households in the exposed area. These are the kind of measurements that you can consider as sensitivity. And finally, the adaptive capacity, which is a very critical issue. You can take first, the financial capital, about wealth, the healthcare financing. So different countries, for example, if you go to the US and in the western part, in terms of exposure and sensitivity, there are more population, but because the US has quite significant and adequate adaptive capacity, they don't feel it. So the healthcare financing system the kind of capital allocated per capita expenditure on health, the percentage of budget of national budget allocated at local level, and per capita government expenditure on health could be taken as a financial capital. And in terms of the physical capital, you have the technology and medicine, no, the critical systems, infrastructure, and equipment safeties can be counted at county level or at district level. The status of the health facility system, such as electrical, telecommunication, water supply, waste management, fuel, availability, medical gases, ventilation equipment supply, and access to so many medical equipments could be considered. And the second, in terms of infrastructure, is the healthcare system, the physical infrastructure status. If you consider even here in Africa or in Ethiopia, the kind of physical infrastructure we have in the capital and the kind of infrastructure we have in the pastoralist area in the east are different. And the number and type of health facilities, the health coverage, safe water coverage and trend, latrine coverage and trends could be considered as the healthcare infrastructures that determines the adaptive capacity. And the other profile you have to consider is the water and sanitation, which is the physical infrastructure status, the number and types of health facilities, health coverage, and healthcare waste management could be considered as and the other adaptive capacity is the human capital. I think this is a very critical issue. The community human resource for health. I think we here in Africa are complaining about the brain drain. We are training good doctors, good nurses, good midwives, but whenever they get opportunity, they will migrate to the West. So the health professionals, proportion per population by demographic, by geographic area. So the quality you can consider as a human resource. The number of health extension workers per 5,000 by administration unit, and the number of health development army per households. So these are particularly important in the African context. So this could be due to different reasons, but the migration, the brain drain is still an ongoing, catastrophic event in the African continent. Then the last one is the social capital, the social determinants of health and nutrition, the education, the male education, safe water coverage, latrine coverage. All these could be taken as social determinants of health, considered as human social capital. So once you have this data, if you have this data, but well, documented, well validated, then you can do the vulnerability assessment using this formula, which is the Health Vulnerability Index assessment as adopted from, Livelihood Vulnerability Index. And for those of you, I think, the highly cited paper you can see is one of my paper here. So you can see, you can take this, you can download, and you can see the methodology. The problem here in Africa is not about the calculation, because thanks to so many softwares now, you can do it easily, but the data quality and the availability of that data at the right unit of data collection. And what we have found, I think, to take you as an example, if you look into the climate change trends, this is a 30 years trend that we have found on the different administrative units of Ethiopia. So you can see most of the rainfall is decreasing, while the temperature is increasing. And looking into the analysis based on that formula that we have used, if you look into the exposure, you can see, we have measured two subcomponents, the climate change itself and the hazard. and we have calculated the exposure using the formula I showed you. And you can see that Addis Ababa is less vulnerable as compared with the last one, which is Gambella. So you can see, you can, have the three administrative units, Addis, Oromia, and Redo are less exposed, whereas the Amara, all these five regions are intermediately exposed. But these three regions are highly exposed. And looking into the sensitivity, I think we have measured the climate sensitive area in percent, the percent of the households exposed to the climate sensitive area. What is this? Can you take out the black spot over there, please? So you can see regions in terms of sensitivity, with the exception of the capital city, all the regions are fairly equally sensitive. That means that's a nature-based, because Ethiopia is geographically located in East Africa, where the exposure, the sensitivity is almost similar. And then finally, we tried to assess the adaptive capacity. And this adaptive capacity, the financial resources using 3 indicators, the physical facilities using 7 indicators, the human resource using 4 indicators, and the social determinants using 6 indicators. So totally, the adaptive capacity, average adaptive capacity by region is you can see like this one. And you can see in terms of adaptive capacity as compared, as opposed to the exposure, the less exposed one are highly, they have more adaptive capacity, whereas those regions in the agropastoral and peripheral regions have less adaptive capacity. And finally, we tried to calculate the health vulnerability. You can see the calculation as a function of exposure, sensitivity, and adaptive capacity, which is divided by adaptive capacity. And you can see regions can be classified based on their vulnerability indexes. So the vulnerability indexes, those that are with well adaptive capacity, are less vulnerable, whereas in the positive side, you see all the positive sides are highly vulnerable. And then what happened? In order to convince the policymakers, I think we have made the number into classified the regions into 3 kinds of categories: least vulnerable, moderately vulnerable, highly vulnerable, and very highly vulnerable. And you can see the regions that are least vulnerable, moderately vulnerable, and highly vulnerable, and very highly vulnerable. And also calculated the area coverage and the population in order to sensitize and convince the policymakers so that they can allocate more money to the highly vulnerable communities. But here there was one critical, I think, problem we faced during our research. I think the scale, because administrative political boundaries were entirely representing the different agroecologies. So because of the absence of data at agroecology level, in consultation with Dr. Kutane and his colleagues as WHO, we took the regions, and regions' political boundaries cannot represent this kind of analysis in a scientific way. So translating this assessment into adaptation priorities from evidence, we've identified the evidence, then you have to propose actions and then improve the health system resilience. So when you identify, by the way, depending on the country where you are and the available resources you have, you have to look into three critical issues. One is you have to identify the priorities in terms of the magnitude of the risk, which is the vulnerability assessment, and the population affected, the geographic area and the number of population, and the severity of impacts, and also the geographic vulnerability. In terms of prioritizing actions, definitely there are different actions that you can promote, but cost effectiveness analysis, technical feasibility, equity and vulnerability, and policy alignment with your country are critical issues. And then you can drive implementation. Immediate risk, act now. If there is high impact, scale it up. If there is a feasible and sustainable, you invest. And co-benefits should be maximized, because the co-benefit, environmental co-benefit and socio-economic benefits should be considered when you are prioritizing adaptation options. So for decision, the questions that the policymakers will ask you is what requires immediate action, what delivers the greatest health benefit, and what is affordable and sustainable. Unless you answer these, you will be confronted negatively from your policymakers. Therefore, the key message here: vulnerability assessment evidence should guide decision on what to prioritize, who to protect, and where to invest. This is the whole effort of doing vulnerability. But the scale of analysis should be really considered very seriously. So based on this criteria, in a very consultative way with communities, policymakers, and also the expertise, you can identify the adaptation options. The adaptation options could be 10, 20, or 50. Then, based on those prioritization matrix, you can prioritize which one is for the low vulnerable, medium vulnerable, high vulnerable, and very high vulnerable. You can develop a matrix using multi-criteria analysis using the previous indicators, and in a very consultative way. I mean, researchers cannot do alone. It has to be consultative with the Ministry of Health, the policymakers, and even some politicians at district level could be engaged. And you can really propose a very good adaptation options for your country or for your county, or even at a village level. Now, so implementing this into a higher level following the WHO approach, I think you can follow a three-step analytical approach. That also, if you want the description, I can share with you with the coordinators that what we have made. First one is the impact assessment. What is happening? The vulnerability assessment. Analyze the current and project climate impacts on health and examine climate and health data for trends in temperature, rainfall, drought, floods, whichever climate extreme event have. So the first phase is assessing the climate issue, the extreme events. And then the risk and vulnerability identification comes next, the second, based on the exposure sensitivity and the health system adaptation capacity. Then the vulnerability, certainly, like I said, you can use the detailed methodologies that we put. And the third one is the solution. The solution here, the solution pathways. The solution pathway based on WHO is what can you do for these vulnerable communities in terms of leadership and governance, particularly the African colleagues. You can agree with me. The leadership and governance at local level is very critical. How about the health workers? By the way, we tried to assess the knowledge, attitude, and practices of our health workers regarding climate-related health. You will be shocked about the response. Nearly 75% of the health workers in the rural area of Ethiopia do not even understand that climate is impacting health system. Then the health information. and the products and technologies available in every health system and posters, the health services in terms of the training, and the health finance, the budget. So if you can, align the adaptation options through these solution pathways, certainly the output would be transformed governance, trained health workers, climate resilient healthcare infrastructure, enhanced, sexually related health, whatever services, informed and engaged communities and policymakers, and then you can have a co-benefit where you can have integrated climate resilient health systems that can impact again the climate health adaptation. And I mean, for your interest, if I share the CAP analysis, you can see in terms of knowledge that the average knowledge is only 24%, 24.1% of the health workers understand the, the method and the impacts of climate on health systems. And in terms of attitude, certainly if they don't know it, they cannot have the good attitude. If they don't know it, they cannot have a positive attitude. And the attitude is also similar. And more scary is the practice. In terms of practice, it's only 11.7% of the health workers across the country are trying to implement health-related adaptation or understandings and also practices in their healthcare system. So it's very scary. So I think this team, this group, particularly the WHO group in the African context, should do something on this. And so, again, I'm not going to talk. I don't know how how much I have, but there are also the critical gap in terms of leadership and governance in most of African countries, and we have put also the solution pathways, what to do and what kind of actions should be done at your county level, depending on the political system, depending on the culture and the severity of the vulnerability. You can have your own governance and leadership actions. And in terms of health workers, particularly the Columbia University, WHO, and universities like mine, Addis Ababa University, should be very careful. So we need to invest in healthcare workforce training and incentivize also rural development. And in terms of health information system, we've, there is a very fragmented data systems that do not effectively integrate climate-related health and others. So we can develop integrated health information systems, and if possible, if we can adopt digital health tools, it will be better these days, and actions are also given there. In terms of medical products and technologies, certainly because of climate change, there is a significant disruption of supply chain and limited availability. So, strengthening the supply chain resilience and local manufacturing could be a solution pathway. And actions, I think, again, at a higher level, I mean, institutions like WHO, like international institutions and universities can create awareness to the policymakers to establish this one. And service delivery, I tell you, this is a very critical issue. So expand integrated services delivery models and leverage digital health. So this can be done, strengthen the partnership with NGOs and international organizations, train health extension workers. Maybe Dr. Kutane can expand on this, and also the health financing, unless we lobby the policymakers and government ministries at a higher level, with the amount of money allocated for the health system, it will be very scary to bring a sustainable health system in the African continent, or at least in my country. So in conclusion, I think I'm still keeping my time. So climate change is no longer a future threat. It is a present health emergency. even now, this as we speak, if you go to the Horn of Africa, particularly in the eastern part, you can see how it is an emergency issue. And building climate resilient health system begins with understanding risks, identifying vulnerabilities, and translating evidence into effective adaptation actions. Therefore, I suggest that understand the risk at your village level, community level, county level, district level, and country level. So the climate hazard, the exposure and sensitivity, and identify who is vulnerable, where and why, and use the evidence. If you have that evidence, you can calculate the vulnerability assessment. And that findings identify priority health outcomes, populations, regions, and health system gaps so that you can easily convince the policymakers. And then you can prioritize actions. Here, from my experience, I would advise you no one single professor or expert can prioritize alone. It has to be based on discussions and understandings, and you have to apply multiple criteria analysis in order to select the high impact, feasible, cost effective, equitable, and policy aligned interventions. And that requires also, the feasibility of the interventions. And then you can build the resilient health systems, strengthen governance, workforce, information systems, infrastructure, financing, and service delivery. So the ultimate goal of this kind of assessment is to protect the most vulnerable, maintain essential health services, reduce climate-related health risks, and build resilient health systems. So the key take-home message, my friends, colleagues, vulnerability assessment is not the end point. This is not for academics. I think you can certainly publish in peer-reviewed journals, but it is the evidence base for deciding what to prioritize, who to protect, and where to invest. And you have to take time and quality of work, quality of data, and you have to do this kind of assessment as a multidisciplinary or transdisciplinary, including social scientists, health workers, and also, the economists for this kind of assessment. And having said this, I would like to thank you, and I would be ready to react to some of the issues if you have it. Thank you, Dr. Kutane. Over to you.
Thank you very much, Professor Balai. I'm not going to summarize what Professor Balai has presented. It's very informative. And then from the risk assessment to the action and what to do, how we are going to do. So these are very important, and also the engagement of wider stakeholders in the risk assessment, in prioritization, and also in making a decision to take action. So with this, I think we are going to go to the next session, but you can put your question in the system so that we can pick later on for both presentation. So I would like to I would like to call for Dr. John Bosco. He's going to continue presenting. I just in 1 minute or 2 minutes, let me read his biography. Dr. John is a senior lecturer at Makerere University School of Public Health with expertise in climate and health, disaster risk reduction, environmental health, and WASH. He recently led also the Rwandan Climate Change Vulnerability and Adaptation Assessment and the development of country health national adaptation plan. His research focuses on climate and health financing, gender, equity and inclusion, and the health co-benefit of climate of mitigation measures. Internationally, he is a member of the WHO Alliance for Transformative Action on Climate and Health. He has facilitated the attached webinar and served as an expert for the World Bank Smart Bice initiative. He also led the rural nature-based solution cluster at Makerere University, served on board of management, and is a guest editor for the BMEC Public Health. So we'll hear from here on the case study, and then we'll proceed to the next session. Thank you, and over to you.
Thank you very much, Dr. Kutana, and I hope members are able to hear me.
Yes, we can hear you.
Thank you. So I'm going to be talking about the methods for assessing vulnerability and adaptation, and very much adding to what my previous presenter has talked about. Allow me go straight to how Uganda. I want to share our experience as Uganda, what we did, and how we ended up here. So I want to start with the rationale. How did Uganda end up embarking on a vulnerability assessment and subsequently develop the Health Adaptation Plan? So during COP26 in Sharm el-Sheikh in Egypt, Uganda made a commitment to conduct a vulnerability assessment and develop the HNAP. And by that time, we had the new methodology or guidance framework that had been provided by the WHO to guide conducting the VAA, that's vulnerability and adaptation assessment, and how to subsequently turn that into an HNAP that is well informed by evidence. And I must say that Uganda is among those countries that are experiencing high risk of climate change. We already in the belt that experiences torrential rains or El Nino, and they are projected to actually hit us around September to November this year. The map that you see here shows where the areas that receive above normal, above like 20 millimeters, above 20 millimeters or greater, especially the mountain areas, and you see the central areas where the capital city Kampala is located, with very challenging drainage networks and settlement patterns, but also the mountainous areas being exposed to the risks of landslides. Other low-lying areas, which are fairly flat, experience a lot of widespread flooding. But aside from that, there are also rapid or flash floods that are triggered by climate changes, especially the melting ice, the glaciers on the Mount Rwenzori that cause erratic flooding in Kasese, and they destroyed this Kleber hospital that you see on your left. Now, on the extreme right is the heat map, which is showing the areas that are most vulnerable in Uganda. And you can actually see that northern Uganda is disproportionately at really very elevated temperatures, extreme temperatures. So these regional categorizations of risk, they helped us in deciding which districts to sample from to include. So if we look at the process of doing a vulnerability assessment, The first thing that if you're going to do a vulnerability assessment, you need to have a very good plan, a very good proposal that is having a very well informed scope from what I just described up there. You need to have governance and management systems, stakeholders, and the kind of data that you're looking for. What are you really looking for, and from who? So that so we did that, and we developed a good protocol. Part of it you can find it in a report that's available online. I'll share the link later. And this protocol was presented to IRB or REC because we wanted the findings to be actually available to the rest of the world. And we have already started publishing out of this work. And then the vulnerability, the climate sensitivity, as we'll see, I'll talk about how vulnerability is actually derived from climate sensitivity and the changes in the conceptualization as we have moved forward. So what are we, what kind of risks are we looking at, and among whom are some of the questions we had to put in our protocol so that they gave the framing. And then the capacity. What kind of capacities are we having in the system, or would we want to have in the system? So these are research questions that informed the assessment. These also include the gaps that need to be bridged. And eventually you'll see that these speak to the vulnerabilities, because where they are not, it means the systems are vulnerable. And then about future risks. What do we foresee in the present, but how about the future? How is the future like? Are these hazards likely to increase in frequency, in intensity, in extent, in severity? And then what are the likely health risks that are associated, that can be projected from these increased exposures? And then adaptation. Adaptation. What should be done so that we are able to target where there is highest benefit, or even with meager resources? What priorities can we set from the so many risks that exist? And then after that, getting all this information, then we synthesize the information into evidence-informed action. And that is the plan, the Health National Adaptation Plan, with very clear indicators, monitoring framework, and learning, and of course, costing that will lead to its implementation. So in the planning, we had a core team that was really working on everything, all these documents, looking out for the stakeholders, inviting them, doing the write-up, etc. And this included these people, our expertise I've listed here, a lot in the environmental health, but also public health and clinical, as well as climate science and hydrometeorology. And we had key stakeholders that we had to work with, because the academia was largely coming in as a research partner. But after that, the plan has to be implemented. It has to be included in routine monitoring indicators so that service delivery is sustainable, so that there are budgets that are continuous, and so that it is mainstreamed in other MDAs, other ministries, line ministries that are doing something that affects health. You need support. We had already written these proposals, and we had been sitting with them for 2 years, looking around for who will support this. We tried with the WHO, and we wanted even to split the VAA to be alone, one grant, and then we get the HNAP as another grant. But finally, we got one committed funder, that was the Rockefeller Foundation, who came through and funded both at once. So this is one bottleneck that is failing many countries to progress to do their VA and HNAP. And then technical support. I have already mentioned the role of WHO providing these tools that have seen us through. I want now to speak to the conceptual shift in framing risk, framing vulnerability, as Professor had talked about earlier. You remember he was talking about vulnerability as a function of exposure, of sensitivity, and adaptive capacity. And you saw the calculations and the indices that would eventually come up with. In the real world, when we go to do this, it's quite complex and needs very technical people. And gradually there was shifts. So this framing was done in 2007. And then later IPCC thought through and developed the AR5 in 2014, which was much more aligned to the disaster risk framing, where you say that you look at risk instead of looking at vulnerability and being a function of exposure, and then also a function of adaptive capacity. They are all combined, and then sensitivity. So they introduced a framework that's looking at risk, a risk-based framework, so that the expected outcome there is risk, health risk, the likelihood of something happening. And that is a function of hazard, exposure, and vulnerability. So the rest of the detail is indicated here, but I thought this is important because most of the time people get confused about where these intersect. But you can see the AR5, the risk framing or risk-based approach is what I'm mostly going to talk about, and that's what we used in our assessment. So I want to define those key constructs where we have the hazard as in terms of frequency, magnitude, and duration. So in this case, if we were to take flooding, for example, we would look at the frequency, the magnitude, and the duration. But even magnitude or severity of the flood, you would want to break it out further and assess, okay, how fast is the water? How wide is the extent or the diameter of the flood area or the area that is covering? How deep is it? How fast is it flowing? Then that would give you the severity of that flood. So that's what we're calling like magnitude. And then the duration. So all these different measures are all measuring the hazard. And the hazard could be heat. The hazard could be flood waters. It could be storms, you know. So depending on what you're exposed or you're looking at that area. And then another construct is the exposure, because you want to shape risk. So these are the construct. Exposure. It looks in terms of number of people exposed or entities or facilities that are in the path of that particular hazard, or systems and other assets that are located, for example, in a flood-prone area. And then vulnerability. Remember, vulnerability in the AR4 was the main outcome. But here we are looking at the characteristics. So you can even observe these qualitatively, the characteristics within a system or people that make them susceptible to harm. For example, it could be weak infrastructure. It could be they used a poor mix of cement. It could be the kind of materials they're using, they're not of the right gauge, and they're weak. It could be poverty, they do not have then inadequate preparedness and limited response capacity. This part I want you to take note: limited response capacity, inadequate preparedness. So what is preparedness? When we are going to assess these health facilities, we are looking at what does it take to be prepared. To be prepared, you need a plan at the facility. You need people trained, for example, to show that you're prepared, and you need a budget. So absence of these would mean you are vulnerable. And if you have them, it means you have strong adaptive capacity. So you will see the inverse relationship between adaptive capacity and vulnerability. Then risk eventually emerges as an interaction of these three, but they are happening independently and they constitute risk. Okay, now that I've explained that, I'll move a little faster. So if you look at the vulnerability in a health system, just this is a very common illustration from the WHO, but you can see the vulnerability. It could be vulnerability to any of these, okay? And that could lead to outcomes or risks or health risks. If there is actually a hazard, there is exposure to that hazard, and there is vulnerability. And the health risk now could be to the health system, or it could be a health outcome. There could be diseases, there could be things like injuries, mental health, heat stress, respiratory health, vector-borne diseases, and zoonosis, and others. So it could be anything, eventually the health risk. We visited 43 in Uganda and interviewed or picked data from 716 health facilities. Those were qualitative, and then we did quantitative, and then qualitative assessments from a number of facilities. Most of these, especially the 43, also picked. And we were looking at vulnerability to priority climate hazards where they exist. For areas that were prone in landslide-prone areas, we were assessing vulnerability to landslides, and for flood-prone, for heat, and others, like I showed in the map earlier. And we were looking at how do these hazards actually, what are the vulnerability conditions or the limited capacity within each of these components of the health system: the health workforce, WASH, water sanitation and hygiene and waste management, energy, sustainable energy, and infrastructure, technology, products, and processes. And for each, we were looking at measuring the hazard, and then we measure the exposure, and then we measure the vulnerability and the capacity. So the questions are phrased in such a way that we can categorize on a Likert scale. And like I said, if you see the inverse relationship here, if capacity is limited or is low, it means actually it's almost inverse relationship with high vulnerability. And for you to reduce risk, you just need to increase your capacity, adaptive capacity, meaning that the adaptation plan would then come in handy to deal with everywhere there are vulnerabilities. Okay, what were our key objectives on each of the areas? These are detailed. I will not go through them. I will just flash one of them. So if we're talking about vulnerabilities in the health workforce, human resource, what would be the objective in an adaptive or a resilient health workforce? What would you want to see? And these directly translated into the strategic objectives of the plan. So we would want to see would want to see healthcare facilities with capacity to deal with health risks that are associated with climate change, having a healthy and safe working conditions, and sufficient number of health workers who are aware and empowered and they're able to ensure environmentally sustainable action. So you look at training, you look at communication, you look at other things that would make them resilient. Then we went to WASH. We also had critical objectives that we want to achieve in WASH to build resilience, so that the assessment is going to directly answer. And now here we come with our Likert scale to assess the adaptive capacity. So if adaptive capacity was not there, it meant there is high vulnerability or high risk. So the questions were, is the human resource provided with programs for supporting staff with regards to mental health, injuries, medical treatment, and related support? So this would build resilience. But if it's not there, or it's there partially, then we know what to score here. So you can see that it's pretty simplified. And then you can know where you fall, whether you're at low, medium, or high. And in the previous slides, you're able to compute your risk easily. Okay, so we did that for all the hazards and all the pillars or the elements of a resilient health system. Like I mentioned, the workforce, we did that for energy, we did that for the infrastructure and processes and services, until we were able to compute. Where we would find some narrative or explanation, would take notes in these forms. So what do we mean by major, moderate? It is also elaborated here, for example, in terms of impact. If what you see on the extreme right, these would be major impacts, okay? But if it is something that can easily be restored, then it would be minor. So also these tools are provided by the WHO, all these categorizations provided by WHO. What you mostly need to do is to customize it to your context. Sometimes they talk of sea level rise, but in Uganda, we do not have a sea. So it has to be customized. In some contexts, you find you're experiencing hazards that are not even listed. Like we realized the tools did not have landslides, and we were experiencing landslides. There was also lightning because of the increased storms, heavy storms. So that one, we included it in the tools. Eventually, you create this matrix that summarizes where you have the health facility that is being affected, and then you look at the components and the level at which they are being affected by a particular hazard. So you can see the floods here, you can see the storms here, you can see water level rise. This is because some facilities that were near shore, like in Ulisa and along the shores of Lake Victoria, because of increased water levels, were inundated. Others, you would find their water supply systems are the ones that are submerged. And then we were able to have a very good summary. So the findings from that, or in conclusion, from that whole assessment and the huge block of results that we have in the report, we noted that health facilities are exposed to various hazards, but floods, drought and storms were among the top ones, and I will show you how they varied. And there was particularly high vulnerability when it comes to wash services, energy, and health workforce. The challenges, there's limited financial and technical resources to actually build resilience. These are some of the findings that actually informed our priority areas in developing the plan. There's also low awareness. People cannot really explicitly bring out these interactions so that they can design control or intervention measures along the pathways, the causal pathways. So we noted that while floods cause significant damage where they happen, droughts were the most widespread. This is because droughts can affect even those facilities that are not located in low-lying areas, because most of the facilities are located on maybe raised, elevated areas near schools, near churches, and they are not necessarily in the flood zones, but they can be affected by drought. So drought really cuts across a big percentage, and floods followed by floods, and you can see the heat waves were affecting least. That was the situation as of 2023, around or September 2023. The situation must have changed now because climate change keeps on presenting us with new challenges. There was contamination because most of the water sources were not necessarily well-proofed, especially in the rural areas. And now the government is very much aware what to focus on, because where is the risk arising from where the contamination of wash facilities. And then we also tried to pick the information that our colleagues from meteorology were analyzing to try and forge out the interaction between climate and health outcomes, particularly looking at malaria. And we could see a seamless relationship between these indices, but more rigorous modeling is ongoing to bring out a model that could help us actually predict the future. But as you notice that here, we do not have vectors. We only have rainfall figures, average, moreover, and then malaria. But we do not have the other data that is actually responsible for moderating or determining the levels. So these findings were popularized to stakeholders, where the stakeholders were invited to give input and validate, confirm, shared even with lower-level health facilities, because they were invited in all these workshops, as well as the technical staff who were providing guidance. As you can see here, our colleagues from the WHO and Missioner Environmental Health and the team from the School of Public Health. We are all involved in this. We also popularized these findings at global platforms like COP28 in Dubai and COP29 in Baku. And these efforts have continued. And out of that, we're able now to get good input from the stakeholders to co-design the priority areas for the HNAP, which was launched with a vision and mission, as you can see there, to create an environment that is really responsive, adaptive, and resilient within our health system, so that we can protect and promote health and well-being of the people of Uganda. And this is certainly going to be contributed by so many actors and not only the health sector. At the moment, we are at the point of developing guidelines for mainstreaming climate and health actions within the health sector and also beyond the health sector into other MDAs, ministries, departments, and agencies, and partner actions. The priorities identified were very much aligned to the building blocks of resilience in the healthcare system, or what we call the pillars of adaptation. And these were 10. I don't know whether I should run through them, but most importantly is coordination. And this came out very, very clearly even during the HNAP. And the actions here that are currently going on in implementing the HNAP is having a very strong coordination mechanism from the implementers all the way to the government and the funders, because the funders, they also coordinated. They are also focusing and identifying key priorities areas, and we feed them with the information. And at the ministry level, the government level, you find involvement of the Prime Minister coordinating all the others, and as well as the Ministry of Finance. They are forming interministerial steering committee to oversee the action and integrating the action in actions of other ministries. So these 10 components, they are also available in the WHO framework for building climate resilience. We are continuing to engage locally and internationally with partners, implementing partners, development partners, funders, to ensure that we raise resources and both financial and technical to be able to operationalize the HNAP. So far, we have had about 12 meetings of the coordination team, and these have had great successes. So whatever I've been talking about is also available online, and I have provided the links to the detailed vulnerability assessment report, which you should be able to access. You can see it's right on the attached platform, and when you go down, you see it. I don't know if you're able to see my entire screen, but you can see it and download it there, as well as the HNAP. So when you click here on the UNFCCC, you'll see the Uganda's Health National Adaptation Plan. I must mention that this was the second one to follow the new framework after, I think, one in Asia, and then this was the second one in Africa that followed this new approach of using this framework that I just described. I think that is all I wanted to share with you. Thank you very much for your time, and I'm happy to answer any questions.
Thank you very much, Dr. John. I think, I don't know, Daniela, if we are going to go for the question response. But
Sure. We have
yeah.
two more frequent questions that we can address. And I would like to invite Professor Belay to turn on his camera.
Yeah,
and John, you can stop sharing, please.
Yeah, I have shared also with the Professor Balai the question. I hope if he accesses his email, he can look at it. Yeah. Thank you. Over.
You can read the question, Kutan, so people can know
okay.
about the question, please.
Let me open. Yeah, I think the two questions highlighted is for Professor Bala is what are the practical tools, indicators, data source, and analytical method does WHO recommend for conducting climate and health vulnerability assessment, including selecting and prioritizing indicators, calculating and interpreting vulnerability indexes, and adapting the methodology to different contexts and levels, from health, facility, and the community to national health system. Then the second question is, how can VA findings be translated into prioritized adaptation actions, health system planning, budgeting, and resourcing allocation, particularly in resource constraint settings? Over.
Okay. I think the first one is pretty simple and straightforward. And I have tried to explain the climate component is, if you are following the livelihood vulnerability based, assessment, then it will be context specific, and all the methodologies, the profiles, and the indicators are presented very clearly. And to show, to save time, I would advise the guy who raised this issue to look into the paper that I have referred there, because it is difficult. I have to go back and explain all the indicators. But the profiles, the indicators, and the measurement tools are there, but they are subject to be context specific, because in the African context, if you see, and from my experience, the data availability is very difficult, and the accuracy of the data is very, very difficult. Therefore, triangulating the qualitative with the quantitative is good. And secondly, in addition to the interviews and the questionnaire-based surveys, the secondary data, which is published by different organizations, can be used. So I think I can stop. Kutane, you can react also how vulnerability could be assessed. Regarding the second, I think vulnerability assessment is not an academic exercise. It's expensive. It requires a multidisciplinary team, and it requires also, time and finance. Therefore, the end product is not analysis. The end product is how to translate that into adaptation option, how to convince policymakers. So the problem here in African context is we don't properly engage our policymakers, and we don't change our research products into policy relevant briefs that are simple and understandable to our policymakers. So we simply, you know, publish it in scientific reviewed journals, and that is nothing to our policymakers. Therefore, there are ways and approaches to engage the policymakers, and right from the beginning, from the inception of the assessment, try to engage government officials, responsible officials in your respective country, the Ministry of Health, and also other ministries and NGOs, but also, if not, regularly, engage also the policymakers in the process of doing vulnerability. So the end product of vulnerability is proposing, adaptation options for the different vulnerable groups and communities. Over to you, Kutani. Thank you.
Yeah, thank you. Because of the time, we go for Dr. John. We have one question we are going to raise, but before that, I would like to raise issue of clarification for Uganda VA. From the presentation, I realized that it is a healthcare facility, climate resilient, and environmental sustainability assessment using the WHO tools, which is we use a checklist. So, Dr. John, can you clarify if this is a VA, which can be at a province or at a district level, or is it VA for healthcare facility, climate resilience, and environmental sustainability for the healthcare facility? Because these are two separate tools and the methodology. So again, what are the criteria for prioritization of what you have prioritized? Because I haven't seen in your presentation. So the second question asked by the participant, it says, given limited financial and technical resource, how can countries prioritize and finance adaptation action identified through the VA while engaging community and other sectors to address vulnerabilities such as wash, energy, ecosystem, and infrastructure that extends beyond the direct responsibility of the health sector? Over to you. The two questions.
Yeah, thank you. Thank you very much, Dr. Kateni. So your question was was it vulnerability assessment for health facilities?
Is it healthcare facility vulnerability assessment using the WHO tool, which is in the guideline of healthcare facility, climate resilience, and environmental sustainability, or have you used the VA assessment steps in the WHO guideline? So it looks like what I heard from your presentation is for the healthcare facility.
Exactly.
Yeah, this is
It's the VA for healthcare facilities.
Okay, not for the entire country.
This was done in 716 health facilities sampled from the entire country.
Yeah. So how you have used that for the HNAP preparation? Because this is a different tool in the WHO guideline for healthcare facility, not the entire VA. Because we need to clear here, because people are here as to have clear understanding the difference between the country VA and the healthcare facility VA, because we are using different tools. Thank you.
The health facility tool that is available is what was used, and we picked the vulnerabilities and the risks within the health system.
Okay.
And based on that, we built, we looked at the building blocks of resilience in the health system. That is, and it was informed by the data set that we picked from those tools.
Yeah, it was supposed to be titled very well, healthcare facility vulnerability assessment. Yeah, thank you, and over.
Okay, thank you.
Yeah. The
So
second
the
question.
second question was about
Yeah.
the prioritization and financing, I think, of these priorities that lie beyond the health sector. As you notice that I hinted about it as I was presenting, that the next step is developing guidelines for mainstreaming climate and health action within the health and beyond the health to other MDAs, ministries, departments, and partners, whoever is doing something about climate and health, so that they have guidance on how they are going to prioritize these aspects and to avoid also duplication. So these guidelines are talked about within the HNAP, and it's one of the activities that are being conducted currently as we operationalize the HNAP.
Thank you very much, Professor Balai and Dr. John, and all the participants. Because of the time, we are not going to address all the questions. I think the question response can come also online. And thank you very much for this very informative presentation and then engagement. Thank you, and over. Daniela, maybe, do you have something to say, or we can close directly?
No, it's perfect. Thank you so much for all the speakers and all the participants, and I see you next week. Bye-bye.
Thank you. Bye, 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 bye.